Good morning, everyone. I would like to thank Dr. Art for this very kind invitation to speak on a topic that nobody really wants to hear about. Come on, let's be honest. You think you've done the perfect ultra-low anterior resection. Then the patient comes back, God forbid, recurrence, let alone low anterior resection syndrome. Nonetheless, when we've done enough of this operation, we know that, we know that even though we do the operation to effect a cure with total mesorectal excision, if possible, we restore continuity. Yet, even with among the most skillful of us, if we see enough patients, we know that deep down there is a group of patients with poor bowel function. In the past, it's called post-colectomy syndrome. Nowadays, it's recognized as the low anterior resection syndrome. This syndrome consists of symptoms of incontinence or feces and flatus. It consists of urgency, diarrhea, frequency, clustering of bowel movements. Clustering means the patient has to go back more than two or more times within 15 minutes to the toilet. What I'd like to do is, firstly, talk about the pathophysiology about why this syndrome may have to occur, at least so that we feel a bit better. I'd like to talk then about the actual prevalence, the number of patients who have this problem. And thirdly, what we can do about this problem. Pathophysiology starts with the technique of surgery. When we resect the cancer and rejoin the bowel, especially with an intraluminal stapling device, it's been shown that the anal sphincter pressures can be impaired and there can be endo-anal ultrasound proven anal sphincter injuries. Look, even if it's inserted in the hands of the best surgeon, anal dilatation limited to lubricating the liberate convex end of the instrument and inserted by an experienced consultant or advanced fellow, and you compare it with a method of anastomosis, a biofragmentable anastomotic ring, which of course can all be done in the abdominal cavity, but that means that when we do a randomized controlled trial, we'll be comparing patients with high anterior resections. This shows that the patients in both groups, STP and BAR, are equivalent with regard to age, gender, staging, morbidity, adjuvant chemotherapy, follow-up. And this shows the postoperative function. There's really no difference in actual function between STP and BAR groups with regard to stool frequency, continence as assessed by whether it's normal, increased stool frequency, altered lifestyle, occasional liquid soiling, or need for antidiarrheal drugs. But when you look at the manometric measurements, there's no difference before we start in the STP and BAR groups, but 6 weeks after, there is significantly impaired anal pressures in the stapled group, and this persists to even when you measure it 6 months later. Why is this so? If you look at the endo-anal ultrasound, you see in the pre-op patient, the internal external anal sphincters are intact, and in the post-op stapled patient, you can see here there is fragmentation of the internal anal sphincter, and this has been shown previously to occur in about 18% of patients where the staple is inserted, but this is a non-controlled group. And when you look into it in our randomized controlled trial, you can see that the incidence is about 28%, and it is associated with impaired anal pressures. And none of these patients, as you've seen before, are symptomatic. Why is this so? Remember, these patients have high anterior resection syndrome. So I'd like to introduce you to a bit of my personal thinking that anal continence and the control is about the last straw which broke the camel's back. Nowadays, we've all seen patients with weak anal sphincter pressures, but they are continent, and it's very likely that the gastrointestinal tract is able to compensate, particularly with its motility, to accommodate the weakness in anal sphincter pressures. This may be the way things like sacral nerve modulation works. The group at Kogura under Professor David Lebowski has shown that with sacral nerve modulation, it's actually the gastrointestinal tract motility, which improves and compensates, rather than any increase in the anal pressures in these patients. Okay, so you got a camel, you got the first straw, maybe pre-existing injuries to the anal sphincters. Another straw, maybe childbirth injuries to the muscles. Third straw, maybe aging, pudendal neuropathy. Then the last straw, then the camel's back is broken. So what is the last straw in patients with ultra-low anterior resection? We've talked about anal sphincter injuries. We also have loss of vital bowel. This study compares the level of resection versus the functional problems. 32 consecutive patients, 59 years of age, 20 to 12, male to female, followed up 1 year. And this is actually a very carefully selected group. No anastomotic leak, no chemoradiotherapy, no local recurrences. And when you look at the bowel function and compare it with the level of anastomosis at rigid sigmoidoscopy and the physiology findings, all by blinded observers, you see that the less bowel you got left, anyway, the less bowel you had left, the more likely that you have increased in bowel frequency. Oops, doesn't work. Oh, and when you cross the threshold level of 4.5 centimeters, there is a suddenly highly increased chance of getting bowel dysfunction. And when you look at the reservoir, maximum tolerable volume with the level of anastomosis, you find there is a correlation, and it is this maximum tolerable volume. We used to think that this is a measure of the reservoir capacity, but more and more I think that the ability of the rectum to sense, the sensation, the afferent pathways are just as important, which is why the significant factors would be apart from the level of anastomosis, would be the anal sensation. I'll touch on that later. Why does this happen? Look, this is after a well-done or properly done ultra-low anterior resection. You can see there's no mesorectal fat left. You can see that the anal stump is stapled off just right at the pelvic floor, the levator ani, and you can do that because the Waldeye's fascia has been incised from the abdominal side. This is a diagrammatic view. You can see that you removed a rectum with the ability to compensate, ability to distend with and accommodate with a non-elastic piece of colon. And worse still, this is not actually what happens in the diagram. In actual surgery, or should happen, there's much, much less rectal stump left. And what it does is that it shifts the pressure curves towards the left so that with a smaller volume of fecal content, there's a much higher pressure, and that may lead to a higher risk of bowel dysfunction. We can look at it more closely with ambulatory anorectal manometry techniques, which allows, like this instrument shown here, allows for continuous monitoring. It's more physiological and more reproducible. And this is a randomized controlled trial looking at patients with the straight and 5-centimeter colonic J pouch. Mind you, it's been shown that the 5-centimeter small colonic J pouch doesn't act as a reservoir, but probably affects the motility, such as reverse peristalsis, to bring about better function. These are well matched, and the colonic J pouch function is better at 1 year. And if you look at the ambulatory physiology findings, the most striking thing is the anorectal pressure gradient. You can see this is significantly better in the colonic J pouch group, and maybe we can better understand it when we look at the graphical display. You can see here that the higher your rectal pressures, the greater the chance of increased stool frequency. But with the colonic J pouch group, with the enhancements that's been done, it's able to tolerate and withstand higher changes of rectal pressures before having stool dysfunction. Let's look at rectal sensation as possibly a way that explains how the bowel function improves or adapts over a longer period, as we mentioned just now. This is a very special instrument, nothing fancy though. It's a computerized pump called a barostat. It controls the inflation rates, pressures, and volumes. There's the ramp distension program, which just gradually brings up the pressure at 40 mils per minute which actually measures the sacroparasympathetic sensations, compared to the phasic distension, which gives random bursts of different pressures from 10 to 70 millimeters mercury, which measures in addition the splanchnic sensation. This is a group of patients at follow-up from a randomized controlled trial. No difference between J-pouch and straight with gender, age, staging, radiotherapy, and follow-up. Bowel function at 6 months, much better in the colonic J-pouch, significantly better. Soiling at passing flatus, also significantly better. And if you look at 2 years, there is significant improvement in both groups, so that it's no longer any difference between the straight and the colonic J-pouch patients, with regard particularly to stool frequency, incontinence, even difficulty in emptying. Some studies have not replicated these results, probably because they used the sigmoid colon for anastomosis rather than descending, or maybe, and also because the stool clustering that they've reported is significantly worse. Okay, let's look at the barostat pressures. This, of course, remind you, measures the sympathetic improvements, and you find that although not significant, there is great improvement both in the straight and colonic J-pouch groups, which suggests that afferent sympathetic function is important in adaptation. Okay, what have we talked about? We've talked about ultra-low anterior resection, impairment of anal sphincter pressures, and fragmentation, loss of vital bowel. It's also been shown that after ultra-low anterior resection, the rectosphincteric inhibitory reflex, this is the reflex that's mediated by the nerves that run inside the wall of the bowel between the anus and the rectum. That's also impaired, and that can recover with time, and it's postulated that perhaps recovery of bowel function may be related to this. We've talked about colonic adaptation. Of course, with chemoradiotherapy, there may be fibrosis of the neorectum, there may be direct injuries to muscles, there may be injury to the pudendal nerve, and of course, with anastomotic leak, there is infection and fibrosis, and of course, we always have to look at recurrence. So at the end of the day, in the medium term, after colon adaptation has occurred, well, how many patients are walking around out there with this problem? Trouble is pure, it's badly defined. The prevalence literature is 28 to 90%. I don't know about you, but to me, it's difficult to understand such a wide range. That may be because we're comparing apples to oranges and throwing in a few bananas as well. As we discussed just now, this is a group of patients which may have differences in adjuvant therapy, different types of anastomosis, different post-operative care, but most importantly, at this point in time, we do not even have a proper definition of what is low anterior resection. Because of that, we are all measuring this with different rulers, and of course, we come out with different results. The most significant advance, I think, at least, is by Emerston and Lorberg. They take into consideration that low anterior resection is benign. So it is a problem if the patient's quality of life is affected. So they sent out a questionnaire, and they found out that the quality of life is most affected by incontinence of flatus, incontinence of stool, frequency of bowel movements, clustering of stools, and urgency. And when they develop a score based on whether these symptoms are present, they have a classification of no low anterior resection syndrome, less than 21. Minor LARS, 21 to 29. Major LARS, 30 to 42. And this is highly reproducible, and it's validated against other gastrointestinal quality of life measures on international level across countries. But to me, a simple surgeon, the most meaningful thing is no LARS means no impact on quality of life. Patient very happy. That's all. Minor LARS, some symptoms. The patient doesn't want treatment. The quality of life not badly affected. So that's good. And thirdly, major LARS, 30 to 42, which means that the patient is suffering and needs something done. Alex Cruz from my group looked at all the literature published on low anterior resection syndrome, 371, and 11 of them used the LARS scoring questionnaire. And these are the 11 studies. They've ranged from 2012 to 2017, mostly from Europe and, surprise, surprise, also one study from Thailand. The numbers range from about 21 to about 900 plus. The incidence of major LARS is about 18 to 56%, minor LARS about 17 to 50%, and most of these patients had no anastomotic leaks. More importantly, if we look closely at the ones with the biggest incidence, 56% from Hughes, biggest prevalence, they've included patients who were assessed less than 1 year before colonic adaptation is occurred. You look at the smallest prevalence, 18%, from Eckarat. They looked at patients where neoadjuvant therapy were excluded and where 40% had included patients with upper rectal cancer, probably not having had a total mesorectal excision. And so, this is the meta-analysis. It shows the prevalence of 41%, which much narrower, 95% confidence intervals of 34 to 48%. And even when we exclude the study from Eckarat on the left, and I can't use this, and the study of Hughes on the right, you find that the incidence is 42%, and the confidence intervals are not much different. And when we did a systematic review on the factors which still affect low anterior resection syndrome, neoadjuvant chemoradiotherapy, radiation, including post-operative radiotherapy, anastomotic height, including the extent of mesorectal excision, remain important through all the studies. The duration of having between the low anterior resection and the defunctioning ileostomy seems to be significant in some studies, but not in others, which may or may not be related to anastomotic healing problems. Age is inconsistently significant, gender is not significant. So, we know that there are 42% prevalence of patients after our brilliant ultra-low anterior resection which are wandering around. So what do we do when these patients come and see us? Obviously, we can't say, can't you appreciate I cured you from cancer? Go away. We got to do something. Well, obviously, first thing we do is to reassure them that there is a good chance of adaptation after about 18 months or 2 years. Secondly, we can prescribe soluble fibers such as psyllium and antidiarrheal drugs such as Imodium. We can advise them on a diet, but there's no good data on diet. That's why I show pictures rather than figures. Shows firstly, tell the patient to stay off fruits and vegetables. Secondly, things like rice, pasta, banana. Patients in Thailand will appreciate this. This is a normal Thai diet. Will be helpful, as such as other starchy foods such as potatoes and avocado. But there's still some patients who do not have any improvements after all these measures. This is one of the study from our group, which looks at failure to respond to diet and medications for more than six months using biofeedback therapy. 19 patients had this treatment. 13 were with ultra-low anterior resection, mean age 64, duration of symptoms 18 months. You can see here that there is significant improvement in the incontinence score, the flatus score, and the reduced solid and liquid fecal leakage score. And you can see that there is significant subjective improvement. The overall satisfaction is 8. Anorectal manometric measurements show no improvement whatsoever. That's probably because biofeedback doesn't retrain the muscles to become stronger, probably helps in coordination. I think maybe even it affects GI motility, because with slow transit constipation, colonic inertia, biofeedback seems to work. And if you look at the quality of life, after completion, using the FIQL, a well-recognized quality of life score, there is a significant improvement in the domains of lifestyle, coping, and embarrassment. And this persists at 2 years follow-up in the 63% of patients who responded to questionnaire, and 75 of these patients had continued exercises on their own, which is known to reduce the risk of regression. Obviously, nobody likes to listen to biofeedback, not sexy enough. So maybe we can talk about sacral nerve modulation. This is a sacral nerve modulation with a time lead inserted the S3 foramina and curving downwards and laterally to stimulate the nerve. This was done in 12 patients, all with permanent stimulator implanted. 33% were men, mean age 66 years, interval from total meso excision to the stimulation 54 months. See, we don't just go straight ahead and do sacral nerve modulation on these patients because firstly, they may improve by colonic adaptation. And also, you'll appreciate if we get this device implanted in the sacrum, if the patient is suspected to have a recurrence, you can't do an MRI. So expectedly, you would do it on patients here who have early staging or you waited long enough. And this is our group of patients. The anastomosis of all varieties. We're doing more side to end because we are doing most of our ultra-low anterior resections totally laparoscopic. And this is the distribution of patients who had radiochemotherapy based on and it's not surprising if you look at the staging. You look at the patients, the median incontinence score is 12, 67% was active incontinence, 75% was passive. Resting pressures and squeeze pressures were impaired. There's pudendal nerve dysfunction in about 83%, external anal sphincter defect in 42%, and internal anal sphincter defect in 58%. Mind you, some of these anal sphincter defect, some of these pudendal neuropathy may well be from other pathology, such as previous childbirth, aging, and the ultra-low anterior resection may just be, again, the last straw which broke the camel's back. So, results, failed timely testing 0, improved continence median 90%, improved quality of life 80%, mean follow-up more than 3 years, and the quality of life was better in patients without internal anal sphincter defect. Okay, you may say that this is just a small study, but thing is, in this sort of the conditions, it's very hard to collect a lot of patients. And you look at the other studies that are published previously in the literature, you can see that 12 patients were able to have permanent pacing. It's not too bad a number. Previous biggest number, 10. Improvements in continence, if you convert them all, 90% is not something that is out of fiction. That is quite realistic. Improvements in the quality of life, it's difficult to compare different quality of life measures. Follow-up, 37 months, not too different from the previous higher, longest follow-up, 32 months. So this may be something realistic that we can look at. So at the end of the day, we need to provide our patients with rectal cancer with a better lifespan and a better lifestyle by doing a total mesorectal excision, oncological clearance of the cancer. We give them a better survival, but we have to be cognizant of the 42% prevalence rate of low anterior resection. So what can we do about it? If we realize it, if a patient has upper rectal cancer and where appropriate, maybe we should consider wide total mesorectal excision rather than total mesorectal excision, especially when the results are equivalent. Neoadjuvant radiochemotherapy. Think about it. Does the patient really need it based on the MRI results? Not just everybody go ahead. Don't just, just do everything with a blanket rule. And if necessary, think of a bowel enhancement procedure, such as a pouch or a side-to-end anastomosis. Even in the short term, the improvement in bowel function may be what the patient is grateful for. And knowing that there's a 42% prevalence rate, when the patient comes, we may be cognizant of that and reassure them if necessary, institute proper medication diet, and if everything doesn't work, there are things that we can do, such as biofeedback and sacral nerve modulation. Thank you.